So why is it that people, especially governments, and some of those who should know better, are so confused about HIV? And why is it that despite all the evidence, people persist in believing that HIV and AIDS have gone away? The answers to these questions are enormously complex, of course, but relate as much to what might be described as a developing political economy of AIDS in the UK and internationally as other issues. So what then are the main features of this political economy? Well, there are several. The first, I guess, is what we might describe as normalization, and something which those of us who've been concerned about HIV-related stigma, discrimination, and the abuse of human rights should be concerned about, and indeed pleased about, if normalization brings with it greater acceptance of people living with HIV, of the condition, and of what needs to be done. But we've also seen within this developing political economy an increasing biomedicalization. And I don't say that to knock or to criticize biomedicine in the least. My own background and many of my closest friends were trained within those fields. But nevertheless, biomedicalization is bringing with it, and I think we've seen this in the last 4 or 5 years in particular, a simplification, an unnecessary simplification of some things that we know to be complex. For example, the notion of what's driving the epidemic, lack of knowledge. If only people knew their HIV status, if only they could be tested, then behavior change would follow. We know that's not true from the earliest days. Overly simple remedies. In my country, the bulk of public spending around HIV now goes into improving our sexual health services and clinics. Nothing wrong with that. Clinics should be of the highest quality. But when the bulk of the funding is heading in one direction, the direction of a biomedical remedy, I get worried as a social scientist. And then a limited understanding of what counts as valid knowledge. We all know, clinicians know only too well, that we have to balance sometimes knowledge gained by one route with that gained from another in order to make an informed decision. And the privileging of one form of understanding above all others, as if it were the only form of understanding that counts, is worrying. And then finally, I think, and I don't want to indulge in professional nostalgia, but finally, a lack of memory for what we learned in the past, for what we shared with each other at those early international conferences on AIDS, in Montreal, in Vancouver, in Geneva, in many other parts of the world. If we begin to forget our own history, then we truly will be lost. Let me remind us, or let us remind us all, let us remind ourselves of some of the features that have to be in common, have to be in place in order to make headway against the epidemic. A few years ago, I was asked by UNAIDS to look at the work of several different organizations and initiatives that had shown success in arresting and turning back the epidemic. There were a lot to choose from, and the time and the resources only allowed a few to be focused upon. So I selected 5 or 6 of them. The work of an organization in Uganda called TASO, the AIDS Service Organization, which was absolutely fundamental to Uganda's early success in dealing with its epidemics, although I should say that rates of infection are now rising again in that country. The work in Brazil of the Grupo Pela Vida, many different community groups of positive people and their friends who enabled a public discourse to emerge around HIV in that country in which ownership was widely shared, not just those of a few, but those of many. The work of the Sonagachi Project, which I mentioned earlier, in Calcutta in India. The work of Gay Men's Health Crisis in New York in the earliest days of the epidemic, not in the more recent period of time. And finally, elements of the Australian response to HIV. Australia is one of those few countries in the world which has shown continued success in dealing with its own domestic epidemics, despite some blips and despite some fluctuations. So what was it then that the work of Tasso, Gruppo per la Vida, Sonagachi, Gay Men's Health Crisis, and these other successes had in common? Well, these are the features. And these are the features I would want to suggest we should try to emulate, albeit in new ways, in the year 2009-2010, if we want to make headway against these developing epidemics. The first of them is very important, and it's the concept of social solidarity, which actually you can deal with much better in either the French or the Portuguese language than you can in English, where it sounds a little stilted and strange. But this notion somehow that different players, that different sectors and different agencies and the community, different individuals within a community, by working together in dense and overlapping networks of association, can achieve something which they cannot achieve as individuals or as groups working in isolation. In the context of HIV today, people need to hear about what's going on. They need to learn from the work of others, not just through one forum, like here, or a meeting you go to elsewhere, but in many different settings. HIV should not be the secret that it is in danger of becoming. Instead, it has to become something which once again binds people together. And there has to be a sense of trust between agencies, and a sense of trust between agencies and the communities that they work with. And within communities, there has to be a sense of greater trust than is sometimes the case at present. But secondly, success in the HIV context anyway derives from a sense of inequity or injustice. People need to feel that there's something wrong. Or, and here is a very good English concept, they need to feel that there's something unfair about the situation. When Tony Blair, in my own country, wanted to bring about the changes in the law that allowed for same-sex civil union, the concept he drew upon was that of fairness, not of rights, not of equality, but it wasn't fair that some British people were denied the opportunities to form a stable and loving relationship and family that the others were. And within English, that concept works very well. But within the languages of the communities that you come from and you work with, you may have to find equivalent concepts that will enable people to come together and feel there is something wrong and something that needs to be remedied. In the early days of the epidemic, in my country at least, it was that lack or absence of fairness that galvanized whole communities to work together. I remember my friend Simon Watney once saying how in the days of Margaret Thatcher in England, that as far as the government was concerned, gay men were disposable in their entirety. Well, that was true of some other groups at the time, people who inject drugs, for example, and a whole range of other particular parts of the population. But feeling that there's something to organize oneself around, feeling there's something wrong, unjust and unfair, is also crucial. The third factor that has to be in place is what is sometimes called a sense of generalized reciprocity. And this occurs when one person shares things with another without expecting something in return. What makes the interaction reciprocal is the sense of satisfaction that the giver feels and the social closeness that the gift creates. And in the early days of HIV in England and indeed in many countries, gift giving through volunteering and in other ways was common. It has to be said it's much less common now, as too many of our AIDS organizations have bureaucratized and transformed themselves into the deliverers of services or the developers of the HIV and sexual health sector, as the Terence Higgins Trust in London now describes itself. Its concern is sectoral development. You can see that shift away from individuals, away from communities, to developing a health sector. Fourth, there needs to be dense and overlapping networks of communication through which information can flow. HIV prevention or success should not be known about only by a minority. Specialist agencies within the health and voluntary sectors, for example. But it should be known about by all. I remember again how in those early days, doctors, community activists, educators often worked closely together. They were often the same people. So by day, you might have one occupation, but in the evening, it was a different one. The discourse, the argument, the discussion, the debate was not hermetically sealed into the tracks that characterize the international AIDS conferences nowadays. Nor was it sealed off into different conferences for community, for the social aspects of AIDS, for biomedical prevention, for vaccine development. That progressive fragmentation of our activities and indeed ourselves is, I suspect, destructive within the context of trying to trigger a collective and responsible response. And going with that fragmentation is the lack of trust. How can you trust others if they genuinely are others in a different track, in a different room, in a different place, working on different concerns? Community trust can all too easily evaporate and disappear. And sixth, there need to be what might be described as cultural templates for success that others can look to, be inspired by, emulate in the work that they do. If there's one thing I learned as a teacher, it is that success breeds success. And in this sense, people living with HIV have a central role to play in education, in prevention, in treatment and care, through their presence, through their visibility, and through their leadership. In this respect, it's deeply worrying that in so many countries, positive people's organizations and groups have weakened considerably, if not disappeared entirely, in the last few years. And finally, there's the failure to bring these ideas together in the form of a forward-looking, properly comprehensive response. And this is where I want to talk, or turn the conversation in the remainder of my talk today.